Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay. So good evening, everybody. Welcome to the class, and it's going to be a very conceptual class. I have had a lot of queries regarding steroids in pregnancy. The different kinds of steroids available, which one is superior, when to give, how long a cover does it give, can we repeat the steroids? And one very interesting question I received from, I think, on my personal chat. What do you mean by repeat doses? What do you mean by rescue doses? And can we give these repeat doses, and what are routine doses? Okay, so rescue, routine, and repeat doses. What is the meaning? What is the difference between these three doses? So very, very conceptual question, and I hope I keep answering all your questions as we go. This is basically, very important thing. This is a guideline by the RCOG, and it is a recent guideline 2022, which has come on steroids in pregnancy. The guideline is a GTG, corticosteroids in pregnancy. And from where I have made this entire class, we have taken only the very important conceptual points which are supposed to be read in a GTG when you read a guideline, the Green Dog guidelines, which are the most important guidelines when it comes to RCOG. And I always keep telling my students that, they keep asking that, ma'am, from which guidelines should we say? What do we say? It's given different here, it's given different. It's always going to be like that, okay? There is no hard and fast rule, a thumbs rule in science, specifically in obstetrics. Something which will work very well for somebody might not completely work for the other patient. So guidelines are made only when it is proven that, yes, it has helped these many number of patients. And then, the work profile, the lifestyle, the atmosphere, the climate, the progeny, everything, the epigenetics of one subcontinent and the other part of the continent are very different. The Indian profile of patients and American profile of patients and European profile of patients are very different. So you cannot have a thumbs rule. So remember one thing, just to ease away any confusion, remember that whenever you're quoting a guideline, make sure that you read from just one guideline. For example, if you're studying FGR, fetal growth restriction, just refer to one guideline. That's it. You do not have to read FGR from American and European guidelines. Do not ever do that. There was nobody to guide me through. So what I used to do is, what about ACOG? What does it say? What about this RCOG guideline? What does it say? Oh, this is saying something else in management. It used to be a whole khichdi in my mind. Okay, but what I've tried to do with my notes is that I have referred to just one guideline, and I've also written down from which guideline have I taken. And because I'm there already, one very important announcement, very soon I'm going to be updating all my notes which have been there until now, because already it's been 2 years hence, even of my updated theory course. It's going to be 1.5 to 2 years now, and I keep updating it as we go. So many new guidelines have come up in the market, many new theories have come up in the market, many new treatments, recommendations, management has come up, and I won't be adding them very soon. So I'm starting it, the entire revamp is starting from week 1 to week 15 as we go. Now, at the very outset of corticosteroids, let me tell you that anybody who feels like asking has any doubts, please remember and keep putting it down in the chat, and I will keep responding to your questions. And of course, I'll be asking a lot of questions in this. Let me hear your side of the story, how much you already know, and we proceed with the class. So first of all, why should we give corticosteroids, and why specifically we want to give it in the preterm labor, preterm birth? That's the most important indication, isn't it? So the idea is that we give a course of antenatal steroids 7 days, prior to preterm birth. It reduces, very important now, it reduces what? So it has, this perinatal, it reduces the perinatal and neonatal death, and it reduces the respiratory distress syndrome. Do you see these things over here? Right over here. Can you see these things? Let me take another one. A different color perhaps. Yes. So yeah, this respiratory distress and neonatal, and this death, when I'm saying perinatal and neonatal death, I'm not talking about morbidity, I'm talking about mortality, right? So it reduces the ultimate, the absolute, it reduces the perinatal and neonatal death, and it reduces the respiratory distress syndrome. So please remember these things. Your concepts should be clear. What are steroids reducing? in preterm labor or preterm birth. Why are we giving it? Because we are mostly bothered about the death of the baby. Morbidity, we have time to deal with. Death, it will be, instant. So perinatal and neonatal death, it reduces, and it reduces the respiratory distress syndrome. That's what we're achieving. What are the benefits of corticosteroids in planned cesarean birth? So when you talk about cesarean, how often do you guys give steroids? Let me hear from my students. How often are my students? And first of all, come on. First of all, tell me, when do you ask your patient to get admitted for an elective cesarean section? Can you guys tell me, when are you asking a patient to get admitted for an elective cesarean section? When are you calling the patient? Mostly, in most of the institutes, what week of gestation do you call a patient for elective? So for example, she's a second gravida. Previous one was a cesarean section 2 years back. And she has reached, let's say, 37 weeks of gestation, and she's a low-risk female. You're admitting her, you're calling her for an elective C-section. What gestation would you prefer, guys? My chat box, I need very, very active, okay? There is no point in going on and on and on like this when there is no response from my students. And some of you are very proactive, but others are mostly silent. So today I want everybody to participate. I want you all to tell me, what is your institute doing? When are you admitting a patient? What gestational age are you admitting a patient for elective C-section? So one is with 37 completed weeks. Okay, in my institute, I prefer 38 weeks at least. Okay. What about others? Okay, she is going according to the guidelines, 39 weeks. Okay, another one with 39 weeks, admitted 38 weeks. Okay. If primary, then we'd like to go for 39 weeks. Okay, primary elective cesarean section for breech. Huh? Breech, okay. And previous cesarean section, you would like to do it at 37, 38 weeks. So, mostly you have, everybody is like around 37, 38 weeks where we do the C-section. Now, let's say what RCOG guidelines say. Recommends, nice guidelines. Okay, these are nice guidelines. They recommend planned cesarean birth should not routinely be carried out before 39 weeks of gestation. That's the idea of giving you the guidelines per se as they are. Nice guidelines suggest that planned cesarean section should not be routinely carried out before 39 weeks. So even I'm wrong here. I knew these guidelines. I've always known these guidelines, but I have seen that if you wait till 39 weeks, patient will come in emergency for cesarean section. So logistically and practically, I'm calling them 38 weeks. And according to my institute, there hasn't been a lot of difference. But yes, currently I'm writing an article on it. The morbidity, neonatal morbidity, from doing a cesarean at 38 vis-a-vis 39 weeks, which is why I'm so interested in this question and this answer from all of my students. So yeah, neonatal mobility at 38 and 39 weeks, I have not seen a lot of difference, but yes, I've seen the other way it becomes very cumbersome. You call them at 39 weeks and all of them always, mostly, they come at 38 plus 2, 38 plus 4 in emergency at night, and night where you have to go and get her operated. Yeah. So, and at night, in private institutes, sometimes you do get, sometimes you don't get the entire team. So, you're like putting her in risk for actually a benefit of questionable results. Correct. So now you got the recommendation. The NICE clearly states not before 39 weeks planned cesarean section. No, don't do that. But for whatever reasons, if for women undergoing planned cesarean section between 37 to 39 weeks, like we've been doing, an informed discussion should take place about the potential risks and benefits for a course of antenatal steroids. When I was about to get my C-section done, I was given steroids even at 38 weeks. Okay, so this is what they're saying over here about the potential risks and benefits of a course of antenatal corticosteroids, and I will be talking about these potential benefits and risks later on. Although antenatal steroids may reduce admission to the NNU for respiratory morbidity, it is uncertain if there is any reduction in respiratory distress syndrome or transient tachypnea of the newborn or NNU admissions overall. So basically, they reduce the admissions, they reduce the admissions for respiratory morbidity. See, they're reducing the admission to NNU for respiratory morbidity. But you never know that there is any reduction in RDS or TTN or overall NNU. NNU, if the patient, the baby is going to NNU for respiratory distress, for respiratory morbidity, yes, that will be severely reduced because of this antenatal corticosteroids given to a patient somewhere around 37, 39 weeks. But it will not reduce respiratory distress syndrome frank. It will not reduce TTN frank, and it will not reduce NNU admission overall frank for whatever reasons. And at the same time, they may result in harm to the neonate by causing hypoglycemia and potential developmental delay, none of which has been actually proven. And this stands as the strength of recommendation.